Good morning, everyone. Probably the infected pancreatic necrosis session is one of my favorite sessions because as a gastroenterologist or a GI surgeon, you struggle every day for each patient. And believe me, each patient is very difficult, unique to treat, and you have to devise your approach differently for each patient. So let's discuss this part, percutaneous endoscopic necrosectomy. So we'll discuss under these headings why there is a need, in whom this is required, success rate, advantage, disadvantages, adverse events, and the future perspectives. As you all know, the initial phase of acute pancreatitis is predominantly a sterile inflammation, and subsequently the necrotic pancreatic bed that gets infected by the bacteria, which causes infected necrosis, which causes secondary organ failure, which is primarily due to infection, sepsis, resulting in subsequent delayed mortality. So we are going to focus on this part. So as you know, infected pancreatic necrosis is now defined on the basis of a suspicion in a patient with necrotizing collections, patient developing high-grade fever, and sepsis without any other focus of sepsis. And we usually don't aspirate to confirm it, and if you do a percutaneous drainage, if you get some organisers, that's a confirm. But most of our decisions are on the basis of suspicion only, and that's when we treat. So if you discuss rapidly, in a patient with necrotizing pancreatitis, in a sterile necrosis, the mortality is around 8 to 13%, and infected it is somewhere from 20 to 35%. So these were the data from Dutch pancreatitis group, which is published in Gut. The patient with pancreatic necrosis and organ failure, the mortality is more than half. That was 55% in the Dutch pancreatitis group, and in all comer it's around 27%. Our data also shows similar results, and but however the Dutch pancreatitis group cohort, they excluded the patient with pancreatic bed hemorrhage, bowel fistula, and all these patients with very high mortality, up to 60% or 70%, those were excluded in this cohort. So if you discuss, approximately half of the patient you can manage with PCD and antibiotics, and approximately half or nearly less than a half, around 40% of patients that require necrosectomy in all comers with necrotizing pancreatitis. And there has been recent study by this Dutch group that was published recently that has shown the similar results also. So if you discuss the evolution of intervention in necrotizing pancreatitis over time, in 1980, surgery for all patients with necrotizing pancreatitis with very high mortality. 1991, there was a concept of non-operative management which is feasible in patients with necrotizing pancreatitis. Subsequently, late necrosectomy was better than early necrosectomy, which my friend Guru showed. And 2000, the first transgastric endoscopic necrosectomy was done with EUS modality, and subsequently over time, the study by Dutch pancreatitis group by Professor Gerg, which has shown that 35% of patients don't need necrosectomy with even after percutaneous drainage, and minimally invasive approach is better than open necrosectomy. And subsequently, the studies by Tension trial, Miser trial, which has shown endoscopic approach is equivalent or even better as compared to minimally invasive surgical approach. So what do we understand by infected necrosis? In most of us, this is the situation. There is a large collection which is localized to lesser sac, and if you do put a metal stent, or if you put do an endoscopic transluminal necrosectomy, you have done your job and you can go and do the debridement. But that's not the case. If you see the large cohort of the randomized trial, but Tension trial by Dutch pancreatitis group, there was 62% exclusion criteria of all patients with infected necrosis. In the Miser trial, 59% exclusion of all patients with necrotizing pancreatitis. Why so? Because what we see in our practice is collection of these kinds, and these are not usually amenable for endoscopic transluminal drainage. What you do, you put a percutaneous catheter drainage initially to drain this collection, and you struggle for months for this patient to take them out of sepsis. So a substantial proportion of patients are not suitable. So if you see, so this has been the approach at our institute. If the collection is partially encapsulated in close proximity to stomach or duodenum, you do the endoscopic drainage, or it's laterally placed, you do the percutaneous drainage, and you wait for a while for the patient to improve, or if there is persistent sepsis or infection, you do the transluminal necrosectomy or percutaneous necrosectomy, which is called PEN, or video-assisted ectoperitoneal debridement. If you go a little bit about history of the percutaneous endoscopic necrosectomy, it was first described in 2000 by the surgeon called Carter. He initially described 3 patient case series in whom he did the surgical debridement and additional necrosome, which was there. He used a flexible endoscope to remove them. And primary percutaneous necrosectomy without the need of surgery, he described a series of 10 patients. And he described that it's being better done with rigid nephroskop. You can take chunks, and endoscopically it was very difficult because subsequently, in the same year, endoscopic transluminal drainage and necrosectomy were described, but this modality, again, a favor of this modality had evolved over last 25 years, but percutaneous endoscopy necrosectomy, there are a few case reports in next 10 to 15 years, and this was the paper which is published by Professor Pramod Garg from our institute, and in this paper, we have shown that in patient with infected necrosis and ongoing sepsis, you can see the X-ray on the left side that is showing a patient who is on mechanical ventilation with whiteout lung, and he has infected necrosis, and you do a percutaneous catheter drainage, and you use that catheter route to take out the liquid pus. The septicemia gets better, patient's organ failure improves, and you can use as a bedside tool to do a subsequent necrosectomy, and patient tolerates better. You don't need a general anesthesia for this, and this can be done as a bedside tool in ICU, and the initial success rates were better. And this is the process. You go through the adult endoscope into the cavity, you wash and take out all the liquid pus, the septicemia and toxemia gets better. So what are the absolute indications for percutaneous endoscopic necrosectomies? Some indications are predominantly laterally placed collections in a patient with ongoing or worsening organ failure who are not suitable for a surgical intervention, or this can be done as an initial measure in a bedside in the ICU. Extensive gas in the collection with poor US window, these are other indications. These are the relative indications. Nowadays we are getting more and more MDR and XDR organism, and you are left with only 1 or 2 antibiotics like polymyxin or tisacycline at the end of the day to begin with, and in those cases you try to take out all the necrotic debris so that to hasten the recovery. And there are some contraindications. So there are some prerequisites you need to check prior to do a percutaneous endoscopic necrosectomy. The location, quantification of necrotic bed debris. Obviously, you want to drain the collection, and you need to upsize the catheter track. So if we discuss our location, this was our classification which was proposed, which depending upon the location, it can be lesser sac, divided by L, on the gutters, on the pelvis, or on the omentum, or it can be extensive. So if you can see, this is the lesser sac predominant collection, L, left paracolic gutter predominant collection with small lesser sac component, right paracolic gutter predominant collection. This is collection located in omentum, that's others. This is the right paracolic gutter plus pelvic, and this is extensive collection with 2 or 3 more, 3 or more components interspersed in the abdomen. Quantification of necrotic debris is usually done by ultrasound or MRI, and then we discuss about tract size upgradations. Once you decide to drain, you put a bigger tube catheter, usually 12 or 14 French catheter. Our initial studies with placement of catheter 18 French or more, it was associated with more percutaneous bleed. Since we usually recommend first catheter to be 12 or 14 French, and gradually once you upsize it to 18 French, once you go to the 18 French, your ultra thin scope with 5 mm diameter can easily go into the tract, and gradually you can upsize it regularly, or you can put a percutaneously fully covered esophageal SEMS. The discussion was going on in the previous session. So this is how you do the percutaneous catheter drainage and gradually upsizing. So I will show a video of this collection, which is a lesser sac extending to predominant paracolic gutter. Initially we do the percutaneous catheter drainage. Now you go inside the cavity, and then it's the same track we used to measure the length of the tract with the rise tube initially. Then you insert the fully covered esophageal SEMS, and under vision you can expand the SEMS. So usually we put a fully covered esophageal 18 mm SEMS, and post-stent deployment there is a lot of pain, because if it is intercostal or subcostal area, sometimes we need to give the local blocks, and subsequently you need to wait and watch for 24 to 48 hours. In the next session, you do the necrosectomy and then you remove the stent. We don't put stent for a longer duration. And during the initial endoscopic lavage, you need to remove the adherent liquid pus. We do it in on carbon dioxide and repeated gentle suction and withdrawal rather than a prolonged procedure with increase in pressure of the cavity that is avoided. So this is the process of endoscopic necrosectomy. You would dilate the catheter with a CRE balloon, usually in 12 to 15 mm CRE. Then you check X-ray whether it has expanded properly. So you can do the repeated dilation prior to the necrosectomy. You go through the stent and you take out large chunk of necrotic debris, either in a single session or multiple session on alternate day. But usually we take out the stent after 24 to 48 hours, and the stent is only used to dilate the tract and do the initial necrosectomy. Subsequently, you can put a 36 French or 34 French catheter to use that to keep the tract pattern. So these are the repeat procedure, and these are the necrosomy we can get from that. So if you discuss about the outcomes of PEN, this the PEN terminology was initially used by Professor Pramod Garg in his 2015 paper. Subsequently, it was being used repeatedly by multiple authors, and we will see this subsequent publications also. And if over years there are multiple publications, and these are the major studies which has included some patients, and the success rate is from 65 to 100%. And we'll discuss about some adverse events, but those are not so many if done well. So this is the largest series, 53 patients with PEN and 80% success rate, and 8 needed surgery and 11 died. And independent prediction of mortality was more than 50% necrotic debris and early organ failure. If you discuss about the adverse events, the predominant adverse events was bleed inside the cavity, which is during your debridement, there is some ooze from the cavity or some vessel get injured, and there is some instance of peritonitis post-procedure you have to manage conservatively, and if the patient develops frank peritonitis and organ failure, you have to go for surgical interventions. Pneumoperitoneum, which is usually managed conservatively, organ valve is viscous perforation. These are the other complications. Long-term complications are being pancreatic fistula and recurrence of the collections. So this was one of the protocol which you used once you place the catheter. So usually these patients are hospitalized for a longer duration, but we devised a methodology. Suppose in the third or fourth week you place a catheter, you do a rapid tract upsizing using SEMS or other modality, and you go proactively take out the debris, and within 14 days you can clear the cavity, and within next few days after clearing the cavity you can send the patient home back. So if you compare ETD versus PEN, endoscopic transfemoral drainage, that usually requires general anesthesia, endotracheal intubation, and it is not suitable for patient who is critically sick. Our PEN can be done in conscious sedation, can be done on bedside procedures in ICU, and that is well tolerated by patient. And I was very happy to see the number of publications that has gone up over last few years, 2025 till now. We have 25 publications in the PubMed, and in his review article in Gastroenterology in 2019, Guru gave this figure which is showing PEN as one of the modality for managing infected necrosis. And this is the editorial which is written by Guru, and he has clearly shown that it is one of the promising approach in carefully selected patient. So do you need to compare between VAD and PEN? I don't think we need to compare. We can combine both modality. And my colleague, Dr. Anand Narayan Singh, we have done few cases where you can use both modality. One of the track you use the superiority of VAD being this have a rigid instrument and they can take out large chunk of necrotic debris. And PEN is you have a flexible endoscope, you can go deep into pocket. So you can combine both modalities. And this is a video where the vision is being provided by an endoscope, ultra-thin endoscope, and the larger chunks of necrotic debris are being removed with the help of rigid laparoscopic accessories. And subsequently, the small necrotic debris, we put an adult endoscope and take out all the debris. And in a single session in the OT, you can complete the procedure with both modalities combined. So, and recently we are planning to conduct a randomized trial to compare minimally invasive endoscopic and minimally invasive surgical modality, which includes these both modalities along with transgastric approach also. So to summarize, it's a evolving technique for necrosectomy, better suited for laterally placed collection. It can be performed under conscious sedation in sicker patients. Overall success rate is similar to other approach, transgastric approach, and it's around 80%, and future trials are needed to compare it with minimally invasive surgery. So I would like to thank Professor Pramod Garg, who was initially defined the modality, improvised upon it, and now many centers across India are doing this procedure, and even many centers in the China and across the world, they are doing this modalities, and over years, the technique, the success rate, and other modalities have improved, and we are eagerly waiting for some necrolytic solution, which my friend Dr. Venkat is trying to develop over time, so that the necrosis solution necrosome get dissolved, and we can aspirate all the necrosome from this cavity, and this modality can be used in more and more patients. Thank you very much for your kind attention.